All right, thank you everybody for coming. We really appreciate it. I'm Nicholas Warset, and along with Sylvia Vaca and Feroz Nana, we're going to be talking about our experience using an OpenEdX medical course to train clinicians in Tanzania how to treat clubfoot. So hopefully we don't get that much of this feedback. We prepared a short video for you to catch everybody up. So we realized Sylvia and I are probably the only medical people here who know what clubfoot is. So we have a video demonstrating that and talking briefly about the project, and then we'll go into more details after. So we hope that you can see and hear this.
Clubfoot is a congenital deformity in which a child is born with their feet turned inwards and downwards.
Not only does this lead to physical disability, but it's also associated in developing countries with very high levels of social stigma that prevent a child from going to school, from obtaining the education that they need to get a decent paying job, and leads to higher incidence of poverty. Every year, hundreds of thousands of children are born with clubfoot around the world, and in developing countries, the majority of these patients unfortunately do not have access to treatment.
We have a lot of challenges in treating clubfoot in developing countries. We have been having a lot of patients here from various parts of this zone, and some have been mismanaged and some have not managed at all.
Do you think my child will walk again? Do you think his feet will look like other kids? That was the biggest worry.
Through the course designed for extreme affordability, a class taught out of the Stanford D School, we were paired up with a multidisciplinary team and international partners to tackle the problem of teaching clinicians how to treat clubfoot with the Punzani method.
The treatment itself is very simple, it's cost effective, and it's easy to be performed.
The Punzani method really fits to the environment in the developing world because it's cheaper. Not only orthopedic surgeons can perform well the treatment of clubfoot, it has been proved that even the paramedics can treat clubfoot using the Punzani method.
We found that medical education in developing countries is highly variable.
In India, we realized that one of the biggest problems was that most clinicians didn't know how to do the treatment.
Back there when we were in school, we never got the chance to practice on site.
Our team decided to create a digital training course that clinicians could access prior to attending a hands-on skills workshop.
We are training different people from the Southern Highlands zone.
We actually bypassed the issue of internet connectivity in Tanzania by providing all of the trainees tablets that had 3G built into them.
It was my first time using the tab for training, but it was good.
The e-training was something new to most of us. What I loved about this particular one was the fact that it was very easy to navigate and it was easy to understand and straight to the point.
People who live very far from the hospitals cannot easily access treatment, so they have to have their clinics close to where they are.
We need to train more people and we need to have more clinics out.
We are training those clinicians, physiotherapists, doctors, assistant medical officers who are really treating children with clubfoot at their centers.
100% of the participants improved their scores on a post-test compared to a pre-test.
I have talked to some participants. They are happy with the training and they think that it's better in the future we can have some more trainings like this.
All 15 of them had said that they'd be willing to take an online course in the future. So in a way, not only are we bringing more knowledge of clinical methods, but we're also teaching new methods of education.
The whole package is contained in this module.
The way we are moving, I think clubfoot will be history in Tanzania.
So I hope that you're able to hear and see that a little bit at least. We're going to be going into more detail about the specifics of our project, and why we think that Open edX is a good fit for us, and also some of the ways we think that the platform can be improved to make it more applicable to developing countries. And also, we've talked with a lot of you already over the past day and a half, and we really hope to inspire some of you to help out during the hackathon. We have some really tangible fixes that we're going to present at the end of our project today that we'd appreciate some help with. So the way that trainings are currently being performed in developing countries follows the standard train-the-trainer model. So what's happening is an expert's coming in, typically from the United States, selecting a few clinicians to teach the Ponseti method, and then leaving the country and maintaining little to no contact with these first learners. The hope here is really that these first learners are going to be able to identify other Ponseti practitioners who will be able to treat clubfoot. But the problem here is that it's only such a small group of people that are being trained in the Ponseti method. For them to have to travel to distant parts of Tanzania, to the rural areas where people need to be trained, it really takes away time from the treatment. So here we also see that these first local learners really become the experts of the Ponseti method for the entire country, and they kind of take it upon themselves to have more of an advisory role as well. So they keep themselves very busy with not only training and treatment, but also with navigating the local health system to try to improve access to training and treatment for other clinicians, and also organizing national clubfoot networks for treatment and care, and fundraising to get low or no cost treatment for their patients. So as you can tell, these people are extremely busy. In Tanzania, you can count back to 2008 when the University of Iowa fellow came and taught. They led a 5-day training session for half a dozen clinicians, and these are the people that are still leading the charge for clubfoot treatment in all of Tanzania. So they're spread very thin, and they really need a tool that can help them train other clinicians, and that's where us and our course come in.
So our solution to this was creating an Open edX course to transfer the theoretical knowledge. So the way the trainings currently work, we have our partners on the ground identifying people who need to be trained, and they attend a 1 or 2 day training that consists of 7 hours of lecture on the theory behind the procedure, and then 1 to 2 hours of actually practicing how to do it. What we're envisioning and the way we redesigned this was essentially to shift all of that theory into an online course. And so now clinicians can take that at their own time, on their own pace, and then come into a hands-on training ready to actually learn how to do this procedure. So the hands-on training can then be modified to be either smaller regional trainings that can be done with more frequency, or a fellowship model in which the physicians actually go to a nearby clubfoot clinic and learn how to do this procedure alongside of an expert while helping with patient care. All right. Thanks. Yeah. So particularly for us, we found Open edX to be very suitable for medical education in developing countries for several reasons. First and foremost, it's an effective way to disseminate expert knowledge without necessitating the expert to be physically present. This is essential in treating clubfoot because we need to disseminate knowledge of the gold standard of care for this procedure while having limited resources of experts on the ground. Along those lines, it's very low cost, which is again very suitable for developing countries by making it affordable for them. Now you don't have to fly in experts to Tanzania to lead a several-day training and then fly them back, but you can allow them access to this course and really lower your costs that way. We know it's compatible with medical education because it's already being used for that. Stanford Medical School actually runs some of our courses through edX to teach us microbiology. Flexibility was huge for us. It's been proven in several studies now that you don't actually need orthopedic surgeons to do this procedure. You can use physiotherapists and you can use other paramedical officers, which is really important in a place like Tanzania where there's only a handful of orthopedic surgeons for millions of people. And so what that means for our learners, though, is that they come in with very variable experience with this. They can be anywhere from an orthopedic surgeon who has heard of this method before and can run through the course as a refresher, answering quiz questions to check their understanding, or it can be a paramedical officer who's never heard of this and really needs a lot more of that fundamental knowledge to continue moving forward. This essentially gets everybody on the same page, so once you attend the hands-on training, you're ready to go and primed to actually practice this procedure. From an organizational perspective, It's an objective way to measure results. So in the short term, we can look at our standardized pre-test and post-test scores to see what the improvement is. And then in the long term, you're looking at patient outcomes and linking that back to see if you're actually training people. The point of this training is not so much for them to score better on a post-test, but essentially to improve patient lives. And so tracking that long term can also help in monitoring what's actually a good way to teach people this method. So while all of this is promising, there are several barriers to implementation that need to be addressed before we can successfully implement this and uptake it worldwide. The most obvious one we think of is connectivity. Connectivity, however, can mean very different things depending on which country you go to. In Tanzania, for example, you see leapfrogging of technology, which means that the Wi-Fi there is very unreliable and hard to access. However, 3G on tablets and smartphones is actually very reliable and pretty much everywhere. So it poses an interesting barrier in the sense that you either have to go and improve access to this course in limited internet connectivity and offline situations, or you can tackle it by providing a better way to do this on a mobile device. All of our participants had Android phones and they could access 3G on their phones. Along those lines though, the next hurdle to implementation, once you bypass the connectivity issue, is the user experience. None of our participants had ever taken an online course before. And so getting them registered, and a lot of the issues that we actually had trouble with in Tanzania were those first steps that we didn't really expect. Things like registering people, sending them an activation link, explaining what an activation link was for, was actually pretty difficult. It's an interesting case in Tanzania in the sense that all of medical education is taught in English. And this is the case in a lot of countries worldwide. However, everything else is done in their native language. So in Tanzania, everything else is in Swahili. This meant that when we're teaching anatomy and how to do these technical medical procedures, they totally understand English, and it's not a problem at all. But when you try to explain the little asterisks telling you that you can't have a space in your username in English, that actually proved to be a lot more difficult to explain than the medical knowledge we're conveying. So a lot of these details that we took for granted before flying out there were really the biggest barrier for people to get into the course and feel comfortable taking it. Once we actually got into the content, they found it intuitive, and all of them said that they were willing to take another online course, and they would like to see that for other medical training. So it's the first issues that were really the hard part. Along those lines, empowering local champions is really the goal here. Nico and I don't plan on going to every training site on every country to train all of these people on clubfoot. We want them to feel empowered with their local trainers to do that themselves. So this means helping them help themselves by providing more of an intuitive experience, not only on the learner side, but on the instructor side. We can really empower these trainers to go in and feel like they can do this on their own time. So as an anecdote, Nico and I set up the content for this course, and we were actually pretty apprehensive about learning how to use Studio and uploading content. It seemed like a pretty big task. Once you actually get into it, it's very well designed and very intuitive to use. But that first step in getting people to realize that they can do that, and it's pretty intuitive to do, it's a hard part for us.
So we've already seen that OpenEdX can be an invaluable tool for education in developing countries. In Tanzania, it was actually quite successful in training clinicians on how to treat clubfoot and providing children a chance at a normal life. But we also learned that as an educational tool, the learners really enjoy the opportunity to take a course online. They liked being able to go through it at their own pace, being able to go and review content that they were struggling with, and being able to get instant feedback on assessments. So every single learner that we enrolled, we worked with 15 participants in Tanzania, and every single one of them had expressed desire to take another online course in the future. So we kind of see this as a continuous cycle that not only can we be making a big impact here with medical education by teaching people just the Ponseti method, but we can be using this to train clinicians on how to do other treatment options as well. So there's a huge potential impact here. And with the Ponseti method and with Clubfoot, there's already networks for distribution of this model. So we've been working with a few multinational organizations that are waiting for this waiting for us to wrap this up and push it down the pipeline and institute it in other countries. So we really think that with a few minor patches to the platform, you can really help us make a huge difference in how medical education is perceived and performed in developing countries and have a direct impact on the lives of people who would otherwise go untreated.
We have thought of 4 methods to deploy this course in developing countries. The easiest way for our partners to get started in this is using a cloud hosting service with Bitnami Stack. So just use that to use the Bitnami Stack and have an edX instance running on Amazon Web Services or DigitalOcean to host our content. This works very well for countries which have good internet connectivity like Tanzania and India, but not all countries in Africa have 3G access. An alternative we have in mind is having OpenEdX like in a test center like setting. So many of these hospitals have a lot of computers, they have their local area network, but it does not have internet connectivity that well. So we run it on one computer and have other users operate other computers in the network to access the course. The best thing about this is we can have people on site who will help with usability issues like how to sign up, how to check the confirmation email, or how to basically answer the questions and get them started. There have been some developments on this. The major hurdle we are facing is that OpenEdX, the current OpenEdX doesn't allow you to have videos hosted in localhost, and it's kind of like optimized for AWS hosting. So there was one bug patch which is on GitHub right now, and it is to be merged, and it hasn't been tested yet. A third option is to have the videos, course content, and the tests all loaded onto an Android phone or a tablet. This would be the most convenient way, like we can just preload the tablets and give it out to the learners. But however, the current version of the OpenEdX app does not allow viewing course contents or the test. Only the videos can be seen and downloaded offline. And if we have a feature like this, it would be really helpful, as we can, the learners will also get notifications about when the tests are due and what they're currently working on. And basically also fix a bunch of usability issues, like we can't really have interactive drag and drop questions in the web browser running on mobile. We had issues with that in Tanzania. And also the learner would have everything in one place, so he can just click on the app, he'll have the whole course structure, he can see what is progresses, and he can resume easily.
Will be releasing in a few weeks.
Yeah. Yeah. But we're also looking for an offline version of that so that we can view the course content and take the tests offline. The fourth option was directly requested to us by the users in Tanzania. They wanted a pen drive or a CD loaded to the course content so they can try it out at their own time. By providing the same course experience offline, we have a greater possibility of reaching out to learners who would otherwise have no access to the edX experience. As connectivity increases in the future, these learners would be more familiar with the edX platform and would be likely to use it. If we could have a way of distributing our course in a portable pen drive or CD, that would be great. I had spoken around, I had talked to people yesterday, and I heard that Piotr Metros and Ali Hassan are working something in similar. It's called an edX on a box, where they run the edX server on a chip similar to Raspberry Pi, so other users can connect to the embedded computer. The way it would work otherwise on a pen drive would be like you run your own virtual machine or a Bitnami stack on the pen drive and connect it to your computer. But the problem with that is it requires a lot of memory and requires a reasonably powerful CPU, which is not widely available in Africa. As you go across these boxes, these are the potential reach increases, and the development time also increases. So cloud hosting already works, and LANs to servers is almost there. And these are things which have the most impact on people, and as you can reach out to a larger audience. This concludes the presentation. We want to provide an ample amount of time for discussing any ideas you have on improvement, and we'd love to get your feedback on these. Unfortunately, our team can't stay for the hackathon, but we do have a couple of really cool projects, and we'd like it if somebody could take it up, and if somebody's interested in working on that, please, we have this URL put up, and we have the listings over there. So these are like really small bug fixes. In fact, we have a bunch of tasks which should be somewhat easy, like just use an XBlock or just configure it, which we haven't really been able to, we weren't really sure how to do it. If somebody could help us with that, that'd be great. And also a big shout out to Sergey from Raccoon Gang. They helped us with having the testing servers, and they initially helped us with all the technical glitches and how to like go about doing that. Do you guys have any like ideas about how we can go about fixing those issues? Any of you are already working on something similar? We had spoken to a few people yesterday.
And any questions at all?
Yeah.
project, and I really hope that we can push the envelope that way. A question about the model with empowering the local champions. Like, how do you see that happening? Do the people that you train that way, you say that people become the trainers and lead a sort of blended session with some trainees? Will they be supported by an organization, an institution locally to do that? Or do you see a model where they actually be doing that on their free time? Because you were mentioning that that's kind of already how it happens, that people that are trained, the first local learners, so to speak, to do that on the side. So how do you deal with that?
So what happens now is that there's international organizations that support local organizations or local partners. And these are the people who are currently on the ground going. Exactly like you said, they're very swamped for time. And so instead of having them attend all of these trainings and physically teach all of the theoretical knowledge, once the theory is already ready to go, their role would change for that part to mostly be running who's going to be invited to the course, enrolling them, and running that way. Something we found when we actually went was that they would say, okay, that's great, you guys run the online training, we don't know how to do that. But I sat down with a couple of them, were like, no, let me click through here, let me show you the instructor tab, and let's see what all this works. And as soon as they went through that, they were like, oh, I can do this, I can actually click and I can enroll students. And by the time we left Tanzania, they had already added some other people to the course who were like, we want to train them. So a lot of that is getting over that first barrier of, this is not just for tech people, like I can log on to this thing and I can enroll students and look at their grades and tests.
And the other way that would sort of fit into the model is that we'd shift it more towards a fellowship. So these people would be coming in prepared already with knowing the theory of the Ponseti method. And instead of having the trainers go and teach them on a small subset of patients and teach a large number of people, it'd be the exact opposite. It would be a learner or two who are already primed with the theory of the Ponseti method coming into the clinic to help out, treat patients directly and learn at the same time.
Yeah, actually the smaller fixes that probably could be trivial for you. One of them was the ability to submit all the answers together at the end of the test. So right now how we have it is we have a bunch of questions, and for each question the user has to press submit, submit, submit. So instead there's a way to submit the whole answers at the end of a test. It would be great, and we're not really sure how to do that. We have seen it before on some of the OpenEdX courses, but we're not sure how to do that. And one more thing was not to the setup of the course goes like this. We have a pre-test, we have the course contents, and then we have a post-test. And the pre-test and the post-test are the same so that we can measure the improvement in the user's knowledge. So once the pre-test is taken and the user goes to the post-test, none of the previous modules should be visible. The user should not be able to access the pre-test questions or the answers or even the course contents. Is there any way to go about doing that?
So those are things that we could talk about after the presentation as well, just more specific fixes that we're looking for. But does anybody have any other questions about the presentation or our project?
When you provided the training that was shown in the video, where were you hosting your edX instance?
We were hosting the edX instance through Raccoon Gang.
Yeah, like Sergey's, they were helping us with that, yeah.
So we ran it through Google Chrome on a 3G powered Android tablet. And really like the major issue that we ran into there is that we had drag and drop questions where you'd have to like select an object and pull it onto something else, and due to the interface of the tablet, it's just not possible to do those questions through the local or through the Google Chrome. But we think that that could be one of the improvements that would be possible with an app, the ability to like be able to touch somewhere on the page so that the page isn't moving, and also be able to scroll and like drag and align the questions. So we made those questions have it more interactive, but we had to actually remove them before running the training because we knew that they wouldn't work.
Regarding the onboarding experience, did you find that your users already had email addresses a priori, or was that also a step that they needed to do? That's part one. Part two is that for the emails, did you actually use email as a way of communicating with your user base?
Right. So before going to the training, we had already a group of 15 people that we knew were going to be attending, and we sent it out to all of them. We auto-enrolled them, so all they had to do was check their email and click the activation link, and only 3 out of the 15 were able to do that and like finish their registration. When we got there and helped the other 12 register in person, the big issue was that they didn't understand the concept of getting an activation link. Like that was something that, you know, they're not doing that for other processes, so that's not something that's like familiar to them. So when we were telling them like, oh, like we just sent you an email, you have to go click that and then your account will work, they'd be like, well, I already have an email, like why do I have a new email now? Like why are you creating a new email for me? So there was a lot of a time dedicated to that and registering the participants through the email. But yeah, all of the participants do have their own email address. They access email like primarily through their phone, and they'll have data like it'll come and go essentially. So they'll have data when they get paid. Like they'll get paid, they'll go load their phones with data because they don't have contracts, and they'll be able to check and respond to their emails. And since we're working with clinicians, like they all have email because they have to respond to patients' emails and other clinicians' emails.
Do you think it would be viable to do a whole course just on a mobile phone? That would be sufficient for a class and
Yeah, 100%. That's the way that we really think that this would be like the most accessible to all the people that we need to reach with it. Yeah, they were extremely happy taking it through the tablets. They'd never taken a training through a tablet before or even had any experience with an online course, but they really like the experience and they're super familiar using their mobile phones. Okay.
Thanks.
Thank you.
Thank you.